Good morning. My name is Niemer Alkhatib. I am representing here three organizations. Matrix 45, I'm working with them as senior consultant. At Zaytuna University, I'm new to this university as well, as I am also adjunct assistant professor at the University of Arizona Center for Health Outcomes and Pharmacoeconomic Evaluation. It's been my pleasure to be here in this meeting to meet some of you, some new faces, in order to exchange knowledge, see how we can optimize the healthcare system in Jordan, the efficiency of healthcare system in Jordan. My talk will be about the cost method that we are using in our healthcare system. I'm not going to talk about pharmaceuticals because the costing methods for pharmaceuticals is completely different from costing for the healthcare system. So, but today I'm going to focus mainly on the healthcare system in general. We may touch on how we cost the pharmaceuticals. When we talk about cost method, okay, or costing or cost inputs from a healthcare perspective, it comes to our mind like the cost of hospital services, physician services, home care services, if it's available, personal care, pharmaceutical prescription drugs. But the reality, in fact, that costing methods are different. If we are talking about a costing method from the perspective of accountant or from health economist, or even if we are talking about the disconvergence between public sector and private sector. All of these, they use different methods for costing. For accounting, for an example, okay, I'm going to give one example for each. For accounting, what they are interested in is just to report the total cost, the total actual cost, which is in fact different from what is needed by the health economist, because health economist, it's interested in what we call opportunity cost. And opportunity cost, okay, it's not captured usually by accountant. Okay, what we mean by opportunity cost, it's the cost lost due to, for an example, loss of productivity, due to value of time, like what is the value for patient who is waiting 1 hour to see a doctor. Okay, this is a very subjective, and the accountant is not interested to capture this value. But health economist is interested to capture this using different modeling techniques. I don't know, but is my voice clear? Okay, this is good. Now for private sector, I'm sorry. Their interest is totally different from public sector in terms of costing. For a private sector, they are business-oriented organizations. They are interested to develop costing method that fulfill their need for IFRS, which is in fact called International Financial Reporting Standards. But for public sector, in fact, what they are interested in is to know their cash flow, how money we have and how we can allocate this money. I'm going to focus on the perspective of health economists. The problem of health economists that it's not always is interested in or are interested in measuring all relevant costs, but they are interested, in fact, to measure the cost or limit the cost inputs based on the perspective. For an example, if we talk about patient as health economist, I have direct medical costs to be included, direct non-medical costs, indirect and intangible, what is in fact measured by QALY or QALY used as a proxy for these intangibles. I'm not going to go in details, but society, in fact, which is reflected by patient perspective, is the widest perspective or broadest perspective that includes all cost parameters, all relevant costs. So, costing method for health economists, in fact, they are limited to 3 main categories. One is called bottom-up, okay, method, top-down method, which is now a standard method, activity-based costing, I will talk about this, but in fact, activity-based costing is a division or a section from the top-down method that it's a simplified form of top-down method that can, in fact, we can apply it in our healthcare system. Okay, Jordan. Now, what is the best method among these three is how we can, in fact, identify our need, how we have, what data we have, in fact, to measure the cost that we need to plug into our models. Now, we have driving factors to select the cost method of interest. The first one is accuracy of the costing method. We call it external and internal validity. And external validity, the estimates are appropriate for research question. What is my research question? Okay. The measurements also, if are allowed, well-founded, we call it internal validity. The other criteria to select the method is a precision, which means reliability. If I have this model and I need to reproduce this model, what is the reliability of this model? Okay, so these two main, accuracy and precision, two main driver factors in selecting costing method. So, and the factors that affect the accuracy and the precision, it's the degree of disaggregation. And I will talk about this now. The degree of disaggregation, if for an example, talk about micro versus a gross, detailed costing method versus average costing method. How you disaggregate the cost inputs in your model. The other thing is the method of valuation of the resources. Are you using top-down or bottom-up? Okay? In the literature, we have, in fact, something called level of identification of resources items. So, for an example, the top-down micro costing, and top-down, in fact, you start from, your starting point is the average cost or the total cost. For an example, if we go to the Ministry of Health in Jordan, the total cost of treating cancer, for an example, it's $10 billion. We started from there. And then we disaggregate this cost to trace it for patient or per case or per service, for an example. Yeah, we already delayed. We already delayed. In fact, when I started this session, okay, we started at 10.
This session is two parts. One is for also Dr. Anas Al-Muhtasib, I think.
Give me 2 minutes, okay? To wrap up. So, bottom up, it's the opposite, okay? You started from patient level and you go up. No. Now, the micro costing is very detailed. The gross costing is aggregated, a semi-aggregated one. Now, the form or the data that you need for top-down, in fact, it's usually retrospective data. But for bottom-up, you have to create a sample, okay, of patients, and you start asking them how much the cost of each item in their service. Now, I will not go in details. I'm gonna wrap up. Okay. But the idea here, each one has pros and cons. The pros of, or sorry, the cons of what we call it, I'm sorry, why it's top-down. The cons of top-down is retrospective data. Sometimes innovative treatments will be missed. if you use retrospective data over a specific period of time in the past. Now, the pros of top-down is it's easy, it's less time-consuming. While the bottom-up, the issue is not about missing innovative products. The issue is about sampling size of your patients. Is the sample representative to my conclusion or not? So, due to time constraints, I'm gonna just talk about the activity-based costing. Activity-based costing, it's new in the literature. It's more accurate than any other costing method, top-down or bottom-up. It converts all cost inputs at the end of the day to the cost per activity. Okay, I'm not gonna go in details. You are killing me.
I think Dr. Anas Al-Muhtasib is here. Okay, okay.
So there is no white and black in costing method. It depends on what you have in your healthcare system. If you have retrospective data, you have technicalities to use top-down, go and use top-down, but you have to be careful because you need to calculate opportunity cost. If you have the ability and time to go into detailed costing method, you have to use the other form, which is bottom-up, but you have to be careful that you need to resolve the issue of duplicates, because sometimes you reach a point in calculation that you have duplicate numbers, especially services. Now, for what we call it, criteria or checklist, if I have two different forms, if I have a specific form, I need to make sure that I have a checklist. The checklist for the top-down is here. I'm not going to go in detail to too much details. The checklist for methodology of bottom-up costing methods is going to be here. I will leave my slides decks here. If you are in healthcare system, you are responsible for costing method or calculations, you can use this checklist. The trending or tendency in designs in the literature, vast majority, if you use or integrate health economics terms in costing method, not accounting terms, you will end up with the conclusion that the vast majority of publications in costing method are top-down. The nice thing is the vast majority of the top-down are active based costing, okay?